Then ready when you are, Gunther.
All right, I am ready. Thank you all for joining. It's a great pleasure to be here today to witness Lianne Gonsalves' PhD defense. I guess everybody knows the rules, so Lianne can start with 20 minutes presentation, and then there will be the questions. I assume you have slides, Lianne?
Yes, I do. I'm going to attempt to share my screen right now and then maybe ask for some thumbs up just to make sure everyone is able to
I
see
can do that, yes.
the presentation. Okay, so I'm sharing now.
Looks great.
And you just see the slides. You don't see presentation mode.
Looks perfect, exactly.
Okay, so with your permission, I'll get started, Gunther.
Floor is yours.
Thank you. In this presentation, I'm going to be talking about how young people access contraception through private pharmacies using results from a mixed method study conducted in Kwale County, Kenya. So this study focused on young people ages 18 to 24, but the broader category of youth captures those between 15 and 24. And during youthhood, a lot of people become sexually active, which means that they may have need for contraception. Young people can access contraception through a variety of outlets. For example, university and school health programs, public and private health facilities, peer educators or youth centers, shops and supermarkets, and/or private pharmacies. But if we think back to our own time as young people, we might remember that there's a fair amount of discomfort that comes into play when we think about young people and sexual activity. And this discomfort permeates into policies, health service provision, community norms, and creates obstacles that can stop young people from accessing the contraception they need. And this is a problem because youth SRH is important and the challenges associated with ill health are very real. Pregnancy and childbirth complications are the leading cause of death among young girls aged 15 to 19, while 30% of new HIV infections occur among those aged 15 to 25. To date, efforts to strengthen services and make them more appealing to young people have focused predominantly on youth centers and public health facilities, with mixed effects. Private pharmacies, however, have been less studied. Private pharmacies are owned and operated by trained pharmacy personnel, and in contexts like Kenya, once they're open, they operate independently, completely separate from the public health system apart from regulation. We know that private pharmacies are already a valued source for contraception for young people in many countries. One analysis of 33 sub-Saharan African countries found that commercial drug sellers, which include pharmacies, were the source of the most recent contraceptive method for nearly 1 in 5 young people ages 15 to 24. So why wouldn't we immediately turn our attention to strengthening pharmacy services for young people? Well, the problem is, in comparison to what we've done to understand how young people access public health facility services, for example, private pharmacies, by comparison, are a bit of a black box. And we cannot strengthen pharmacy services without first understanding how they're currently used. And so this brought me to the aim of my dissertation, which was to understand what drives young people in need of contraception in Kwale County, Kenya, to access it from pharmacies. Why was Kenya a good fit for this? Well, there's a higher unmet need for contraception among younger women in Kenya compared to women of a reproductive age generally. Additionally, short-acting contraception is popular among young women, and that refers to things like condoms, daily contraceptive pills, emergency contraception, and injectable contraception. And this makes pharmacy access an interesting strategy because those are also the types of contraception that are readily available in private pharmacies. Specifically, this study took place in Ukunda and Kwale Town, which are 2 peri-urban areas in Kwale County, which is a predominantly rural county. The dissertation aim was further subdivided into 3 specific research questions. First, I wanted to understand the experiences of young people worldwide who access contraception from pharmacies, and this was done through systematic literature review. The mixed method study focused on young people age 18 to 24 in Kwale County, and here we wanted to understand who gets contraception from pharmacies and why, and what are characteristics of pharmacy contraception services. I'm going to focus on answering these 2 questions for the remainder of the presentation. The mixed method study took place between November 2017 and March 2018, and consisted of a variety of quantitative and qualitative methods to attempt to understand the perspectives of both young people and the pharmacy personnel dispensing to them. In the study area, we purposefully selected young people to participate in a series of 6 focus group discussions. We randomly selected an additional 740 to complete a cross-sectional survey. We purposefully selected young people who had recently purchased contraception from a pharmacy and conducted 18 in-depth interviews with them to really understand what that experience was like. And then on the other side of the pharmacy counter, we conducted key informant interviews with pharmacy personnel from pharmacies randomly selected in the study area, as well as pharmacy stakeholders, so regulators, people associated with professional associations, and pharmacy-related NGOs. Then on top of that, to add our own third observational perspective, we conducted a mystery shopper exercise where we sent 4 mystery shoppers to purchase either emergency contraception or condoms or inquire as to the availability of injectables. We sent them to 48 pharmacies in the study area where they recorded their experience. Now for the first question, who goes to pharmacies for contraception and why? And I'm going to summarize results that are part of a manuscript accepted into BMJ Open and which pull from the methods you see on the screen. We wanted to know the factors that lead someone to get their contraception from a pharmacy versus any other source. That means that of the 740 young people who were randomly selected to complete this survey, we were actually only interested in those that had ever had sex and who had specifically used one of our contraceptives of interest at last sex, which means that we ended up with 259 young people who we then moved forward for quantitative analysis. Of these 259 young people, we wanted to understand where they had obtained their contraception used at last sex from. We found 59% of them reported having gotten it from a private pharmacy versus the 18% that you see from a dispensary health center or hospital in blue, which corresponds to the public health facility infrastructure. Because we were interested in those who got their contraception from a pharmacy versus any other contraceptive source, I combined all of the other categories that were not pharmacies together and created a dichotomous outcome variable. However, we dropped those who either couldn't remember where they had gotten their contraception from or who reported getting it from an individual. So that resulted in us dropping 6% of the 259, leaving us with 243 participants. From here, we wanted to assess the association between our outcome of interest, going to a pharmacy versus any other source, and a variety of behavioral and socio-demographic variables of interest. So the first column that you see on the right shows us within each demographic who obtained their contraception from a pharmacy. So for example, if you see males, 132 of the 243 participants were male, 61% of that 132 obtained their contraception from a pharmacy. After these descriptive statistics, we then tested the association of each variable against the outcome using a bivariate log binomial regression. Any one of these bivariate analyses which showed a p-value of less than 0.2 moved the variable into a multivariable analysis, which meant that we had a multivariable analysis that assessed relationship status, whether or not the participant had children, their living situation, and the type of contraception obtained. These were included in a multivariable Poisson regression model with robust 95% confidence intervals. And the significant associations are those which you see in red. And so what we found from this analysis is that individuals who were single were less likely to go to a pharmacy than those that were dating. Individuals who were living alone were nearly 2 times as likely to go to a pharmacy for contraception as those who were living with a partner or a child in a more head of household role. And finally, the contraception obtained was itself a strong predictor of contraceptive outlet. So as compared with pill and injection users, condom and emergency contraception purchasers were 1.87 times and 2.27 times respectively as likely to purchase contraception from a pharmacy. That said, if you look back at that middle column, you'll notice that the noticeable proportion of individuals across and within socio-demographic characteristics that do go to pharmacies indicate that, contrary to what I thought going in, there may not be a clear profile of young person that relies more heavily in pharmacies. And instead, pharmacies may be relied upon by a diverse set of young people. And our qualitative findings did confirm this. So if pharmacies are broadly appealing, why is that the case? What's so appealing about them? When we looked at the qualitative methods, specifically the interviews and the focus group discussions, we found that the establishment had certain elements of appeal, the personnel did, and the services themselves. And what we found is that the establishment itself was appreciated for its convenient locations, longer opening hours, and anonymity offered. One young person who had purchased emergency contraception said, "At the hospital, there are a lot of people there and I would get shy, but at the chemist, it's private between me and the doctor." The personnel themselves were also perceived to not give any judgment or gatekeeping, which some participants attributed to the fact that pharmacies are private businesses and it wasn't in their best interest to deny access. They also were appreciated for their interpersonal skills, being of a similar age and easier to talk to. One young man said, "The person in charge of the pharmacy is my friend, and I can go to him with my problems and he would assist me." Finally, the services themselves were perceived to be fast and of a lower cost than other sources, and that includes supposedly free public health facility services. One young person explained it this way, saying, "At the dispensary, you must meet with the doctor, and maybe there's a service you need to pay for. Unlike at the chemist, where everything is fast. You get what you want and leave." So in summary, pharmacies were perceived to offer a more predictable and convenient service to young clients. The second question looked at what the characteristics of pharmacy contraception services were, and it drew from the methods that you see on the screen. And in the next 5 minutes, I'm going to attempt to condense the results of 2 manuscripts and a commentary, so bear with me. So we found in our mystery shopper exercise that young people can successfully obtain contraception. Our emergency contraception shoppers were incredibly successful, and where our condom and injection shoppers were not, it was usually because the commodity was temporarily out of stock. We wanted to know, what does an emergency contraception and condom purchase look like in practice? And what we found from the interviews done with pharmacy personnel and young people was that counseling was minimal. And when it was given, it was often correct. For example, pharmacy personnel claimed that they would tell young clients to be careful not to overuse emergency contraception, which is a myth about emergency contraception. And they told us that they assumed that young clients, if they were asking for something by name, they knew how to use it, and that if they were coming in for contraception, they didn't want any prying or questions. And the youth perspective echoes these assumptions of pharmacy personnel. We found that young clients employed a variety of strategies to make purchases discreet. They might send a friend, or wait until the pharmacy was empty, or use code words or gestures to avoid saying what they wanted and potentially being overheard. And then they would pay and leave in a hurry. We triangulated these with our findings from the mystery shopper exercise and found that in 87% of the successful mystery shopper engagements, where our 3 mystery shoppers purchasing emergency contraception or condoms were given money and told to try to buy it, our shoppers were able to enter the pharmacy, request their commodity, pay for it, and leave. There was no questions, no judgment, but also no instructions. There's no prolonged engagement of any kind. We looked at injection services separately because with injection services, we had the option to not just look at dispensing, but also the potential to see whether people were getting injections administered to them in pharmacies, and whether pharmacy personnel were therefore stepping outside of their allocated role. So we had one mystery shopper visit 45 pharmacies to try to find out whether the injection was available and whether she could be injected on site. She did not actually purchase the injection, and she was not injected. And we found that in 47% of the pharmacies she visited, she was told that she could not be injected in the pharmacy. In 57% of those, she was given a referral to someone who could inject her, and that's completely in compliance with regulations. However, we found in 44% of the pharmacies she visited that she could be injected on site. And through the interviews we did, we found out that this usually happens in one of 2 ways. Either the pharmacy employs a clinical officer or a nurse, someone who's authorized to give an injection, which thereby makes pharmacies a bit of a one-stop shop, or the injection is provided by a trained or untrained pharmacy personnel, which is not in compliance with regulations. And so this brings us to the last part of what we were looking at in terms of contraception services, which is how these pharmacies services were perceived. And what we found is that in the eyes of pharmacy personnel and young people in the community, there were concerns related to pharmacy service quality and consistency. And these related to illegal pharmacies, untrained staff, and counterfeit commodities. From the perspective of pharmacy personnel, it threatened the reputation of their profession. From the perspective of young people in the community, it dampened the trust that they had on these relied upon outlets. And indeed, we mapped 60 pharmacies in the study area as part of this study. And of the 40 whose registration status we could determine by comparing with county records, 25 of them were not appropriately registered at the time we made our comparison. So in summary, pharmacies are an important contraception outlet for all kinds of youth users, and they're appreciated for their relative anonymity, convenience, lack of judgment or gatekeeping, service speed and price. Interactions are short, perfunctory, and successful from the perspective of young people because they get what they want, but quality varies. And that varying quality is a point for concern because what we found in this study is that young people can identify quality concerns, but they have different priorities. So we in the health community, and indeed Kenya's Ministry of Health, says that quality services for young people should be accessible, acceptable, effective, appropriate, and equitable. But what we found is from the perspective of young people, the high acceptability and accessibility of services, those qualities that I mentioned earlier, why they were found to be appealing, were enough to outweigh any concerns about effectiveness or appropriateness or even equitability, because all of these services are, after all, being paid for out of pocket. So where do we go from here? There are implications from the findings of the study that apply at multiple different levels, each of which I'll briefly touch on. So if we step outside the pharmacy for a minute and we look at the broader environment, there's a general need to continue to normalize youth SRH and young people's ability to access contraception. And this can be done through comprehensive sexuality education or complementary health sector policies and programs that target not just young people, but their families, their teachers, their community, and healthcare providers. We need to get to a point where young people can choose their contraceptive outlet because it genuinely is the most convenient thing for them, rather than because they feel shut out from other outlets that might be a better match. When we look at pharmacy services in particular, we know from the literature that improving pharmacy services requires a multi-pronged approach. So a combination of improved public sector regulatory capacity, training and supervising the staff who actually do the dispensing, providing business incentives, so either training owners on business skills or providing some sort of other competitive advantage, and also educating the public, creating client-side demand for quality pharmacy services. If we take this multi-pronged approach and think about how it applies to Kenya, for pharmacy services in general, there is a definite need to improve regulatory capacity. And this can be done through better funding of the public regulatory agency, the Pharmacy and Poisons Board, through responsibility sharing with professional organizations like those in charge of monitoring pharmacists and pharmaceutical technologists, that's known as self-regulation. And then franchising and accreditation schemes provide a combination of all of this, where they provide business incentives with public sector standard setting. And that's also a promising approach that's been implemented in a couple of countries. Additionally, there's a need to incorporate private pharmacies into public health system data reporting. If we can feed service use, including contraception use data, into routine health management information systems, we can provide the Ministry of Health with a more complete understanding of how different public and private health outlets are being used. Finally, we need to strengthen referrals between private pharmacies and public health facilities so that each facility is using its appropriate strengths. And then if we want to go straight into contraception services for youth in pharmacies, some very small things that we can do to improve quality there, or we can target contraception misinformation and discomfort. And this can be done for pharmacy personnel through in-service training mechanisms, which already exist for pharmacy personnel. And then just including private pharmacies in broader youth SRH education campaigns or contraception education campaigns. Imagine going into a pharmacy and seeing, youth-friendly materials that give basic information, address common concerns, and just encourage the young person to have a conversation with the cool pharmacy personnel across the counter. If we work at these three levels, then what we will be working towards is a scenario where a young person can choose a contraceptive outlet based on their individual needs and preferences, and know that whether they're presenting at a health facility or a private pharmacy, they're encountering one part of a supportive web of youth-friendly health services and contraceptive outlets. Thank you very much. And thank you to those who are listed on the slide, especially.
Thank you, Lianne, for a really nice presentation and also for staying perfectly within the time limits. I guess we are now it's time for the examiners. Caspar, are you okay going first?
I can. I would also, shall I? Okay, otherwise I would also give the privilege to Adriane. Adriane, how we shall handle? Should I first or you? Okay, while she's on.
Go ahead, sorry. You can go ahead.
Oh. Would you like, or should I first go? Should I start first?
You should start, I think.
Okay, good.
You go ahead.
Thanks again also for a very nice summary of 3 or 4 years work. And it's never an easy exercise to condense so much into 20 minutes, but very well done. Let me start with 2 methodological questions. The first one is what we have recently very briefly discussed also through emails, this question about the use of mystery shoppers. This is one method you have been using and used it also for your manuscripts. What is your opinion here on ethical considerations to be taken when using this mystery shopper methodology?
Thanks, Casper. I'm a massive fan of mystery shopper exercises after this study. I found them incredibly valuable for collecting data with this research question in mind. I think, so it's interesting, there was that WHO Bulletin article, I think, that we were talking about. And I think when it comes, first there are pragmatic implications. I think that mystery shoppers have also been used in health systems related research a bit, and that was where the perspective of I think some of this new consideration about them is coming from. And I think when you have, like, they can be a resource intensive exercise. So from a resource perspective, if you have the opportunity to say like audit facility data and compare that to things that you can collect from a mystery shopper exercise, sometimes it may be easier to just look at health system side data. The other thing with specific reference to ethics is that there is always a concern that there's a concern about who you need to get consent from. And I'm not sure because people are participating in a study, and so you need to make sure that you're obtaining consent, even if you're observing people in their professional capacity. And so then the question becomes, and I think that this article we were discussed this to some extent, do you have to get consent from, people in charge of pharmacy services broadly, the person who owns it, or the individual people who you might be interacting with? And what's your due diligence there? I know in some other informal discussions we've also had with Adriane, who's I think also been using mystery shopper exercises in her own work, you may also need to consider ethically the safety and security of the people who are the mystery shoppers. And so if you're in a situation where you're sending people in to assess services that might be dealt with one-on-one, and there's the potential for mistreatment by providers, that's something that you need to account for because you're sending your mystery shoppers in to encounter that, and that may not be the most appropriate method to use. In our case, the way that we dealt with ethics for this study is that we got consent from each of the pharmacies at the beginning of the study when we did a geographic mapping of all the pharmacies in the area. So when we did that mapping, we found, we geolocated where it was so we could identify the pharmacy afterwards, and then we went in with a consent form, explained the study, explained what we were doing, and said, if you consent to be visited, at some point in the next 2 months, someone is going to come in and attempt to purchase contraception. And so we were able to get consent from 50 of the 60 pharmacies to do that. And then we also think that that may have mitigated some observational bias we could have observed, because we got the consent and then we waited a couple months. So hopefully it kind of would have faded from people's minds and they'd be acting the way they normally could. And would have that visit that they consented to, but not be thinking too hard about it. Did that answer it, Casper?
Yeah. Okay, Mary, thanks. Then the next question, still methodologically a little bit, going back to your systematic review. I think if we refer to systematic reviews, obviously this is an umbrella term for quite a different subset of different methods. Could be Cochrane, but also many other methodologies often used, Prisma, etc. for systematic reviews. If you would be again at start of a PhD or advising just somebody who starts his or her PhD, what would you advise in terms of systematic review methodology?
I advise to take lots of time because they take so long to do. So to budget that time in, so I think this research question, the systematic review wanted to understand the experience of young people accessing a variety of SRH-related commodities in pharmacies. And so I conducted the review in accordance with PRISMA guidelines, which I consider the gold standard and would happily recommend to anyone to use. The issue, and I think the complexity with a research question like mine, is that what the systematic review found was a myriad example of different study types and designs, different types of participants, different outcomes being measured, which meant that, you know, I think if you're just a student who's come out of a systematic review and meta-analysis class, you know, you're really trying to have targeted outcomes that you can then meta-analyze. And when I looked at all of the studies that, of the 49 studies, I think that I was going to be able to include, the heterogeneity that I saw there just precluded a meta-analysis entirely. So I had to resort to a thematic analysis where I just kind of qualitatively described the themes that I saw, which was fine and effective, but definitely a bit time consuming.
Good. Okay, I have still another two questions. The first one is a little bit more on the result side, and specifically about, let's say, experiences when using pharmacies or emergency contraception. You did not very much go into gender differences. Can you say something here a little bit? Did you find certain patterns, specific one or two key observations in terms of gender differences?
Yeah, I think the qualitative research provides some very interesting insights there. What we found was that when it comes to contraception preferences and outlets for young men, who I think, not just in Kenya, in a variety of different contexts, tend to kind of be closed out of the contraception conversations and accessing ability, young men could go and get condoms, and then they could go in Kenya and pick up emergency contraception without much issue. Young women, conversely, it was not considered appropriate for them to go condom shopping for the most part, but they could get emergency contraception and injectables. So what we found that I would say is really interesting additionally is because condoms, which I believe 72% of the people who were included in the quantitative analysis had used at last sex, so it's by far and away the most common contraception that our participants were using. But condoms are available not just in private pharmacies, but also in shops, which are not remotely affiliated with the health system at all. But when we looked at people who reported going to shops, specifically, a lot of them were young men. So I think pharmacies and shops are popular with youth men. And I think, especially because I know a lot of the global discourse right now is starting to shift to how do we include men more in contraceptive narratives and getting them involved in decision making. I think that this, if we're looking at sex differences, is something that's worth noting and exploring further.
Okay, thanks, Lianne. Last question, and now we go more a little bit to the implications of your thesis. I don't know if you're aware that, let's say, 3 out of those who examine you today have young adults. So basically, children in the age group you have been studying. What would you advise, basically based on the findings of your thesis, to Adriane, Jörg, and myself?
I would say, don't be awkward talking about sex. ever. Just normalize it from day one, and make sure that you know what your young people's ability is to access contraception in Switzerland is. Make sure that they feel like they have a medical provider that they're comfortable speaking with. I remember the doctor I went to when I was a teenager, I would have died if I had had to talk to my general practitioner about contraception at that age. So I think it's really useful to make sure young people have a decent relationship with a healthcare provider. I would also love to see Switzerland change some of its rules with regards to how contraception is dispensed in pharmacies. Something that I find a little bit inappropriate given where the evidence is at the moment is that to get emergency contraception in private pharmacies in Switzerland, the woman needs to go and she needs to ingest the pill on site, which there's absolutely no reason that should be the case. There's no safety issues with emergency contraception. And if we think about how that might dissuade people from feeling comfortable to get something that they need, that's something that I think is probably a hallmark of a slightly older and more archaic notion of contraception and its appropriateness, especially emergency contraception. So I think as the parents of young people and as public health experts, if you want to push for some policy change, that would be excellent.
Okay, thanks a lot. We'll take that and talk to my son this evening. Huh?
Excellent, good. Thanks, Gaspar.
Back to you, Günther.
Thank you, Kaspar. I guess Adrian should go next.
Okay. Congratulations, Lianne. You did a very good job. Really enjoyed the presentation. So I have 3 questions. The first one is really about the methodology. In your sample, you chose urban, peri-urban areas. And I was wondering, did you look into, obviously rural youth have a different expectation and different experience of contraceptive accessibility and availability. And I was wondering if that was a consideration, or if you looked at those issues as you did the background study, or did any comparative work between rural and urban clients?
Yeah, no, thanks. Good question. So the study sites that were used were actually more determined by the fact that the study was partially nested into a broader randomized control trial that I was coordinating for my job. And so I took advantage of having study infrastructure in site in this area of Kwale County to then partially nest the parts of this study. So that's why, for example, I had the luxury of being able to do a cross-sectional survey with 740 randomly selected young people and have that element of, internal rigor. I think I absolutely agree with you. I do think that the generalizability of these findings to rural areas is a limitation, because in Kenya, just as in a lot of countries in the region, pharmacy personnel we have the same health workforce concerns that we have for pharmacy personnel as we do with the broader health workforce, doctors, nurses, et cetera. And that is to say that they are all concentrated in peri-urban and urban areas and do not go or live or establish businesses in rural areas. So I think for Kenya in particular, when I was looking into health workforce numbers to just try to understand this more broadly, I think there's something like 15 counties in Kenya where there's not a pharmacist who works outside of the public sector, which really gives you an idea in some of these more isolated counties that something like a private pharmacy just isn't going to show up on the radar of contraceptive outlets at all. And so my hypothesis, which would need to be researched further, obviously, is that these kinds of people who are looking for that convenience, these kinds of young people, would instead revert to going to shops if they were going to get anything, and maybe rely heavily on condoms, which we know from this age group is by far and away a very popular source of contraception.
Okay. Thank you. One of my follow-up questions was on the number of key informant interviews that you conducted. You did
Are you breaking up?
Key informant interviews with youth, is that correct?
Sorry, again, you were breaking up for a second. Could you repeat?
Yeah, I didn't hear you.
Sorry. Can you hear me now?
Yeah.
Loud and clear.
Okay. I was asking about the key informant interviews. You had conducted 18 with young people, and I was wondering if you felt you had reached saturation with that number, or whether that, how you did the sampling. Perhaps you explained that, but I might have missed it.
No, so the sampling was actually very interesting for how we sampled young people who had recently purchased contraception. We did it in two ways. We found five pharmacies that we had mapped. We developed a bit more of a rapport with the pharmacists who ran them and asked them, hey, if you have someone who looks like they're between the ages of 18 and 24, after they have purchased contraception, we would really appreciate it if you would give them this leaflet. And the leaflet said, hey, we're doing a study, gave them the contact information of our research coordinator, and then we worked to set up an interview, usually within a week or two of the purchase, so that way everything was fresh. Another way we recruited young people was we actually stationed one of our young and very cool data collectors outside of a pharmacy on Friday evening and then over the weekend. And so he stayed outside, and then, you know, again, these were with pharmacies where they had a very nice rapport with the young community and they were willing to work with us. The pharmacist would very subtly give him a look that someone had come and purchased contraception, and he would talk to them and give them a flyer and say, if you are at all interested, please let us know. So that was how we managed to really drill down and find people who had purchased contraception in a recent enough period that they would be able to participate in an in-depth interview about that experience. As to saturation, you know, the way that we ended up, like, through the analysis, seeing that so much of the experience and the appeal depended on the type of contraception you were purchasing, that's the only part that really makes me think that if I had more time, it would have been nicer to do a couple more interviews there. Because, for example, I think definitely reached saturation on what a condom and emergency contraception shopping experience is like. However, I think it would have been nicer to hear from more young women who had purchased injectables, for example, because that is such a, I think young women in that case tend to be in a different life situation. They tend to be married or have had children. And so it would have been nice to hear a bit more about that. It's also the reason that we had to, I dropped, I'm not sure how much you noticed, but dropped the reference to daily contraceptive pills, because one, the quantitative survey showed that only 3% of young people had used that at last sex, and then no one who was purchasing, none of our young people were talking about using them much, and even the pharmacy personnel said, nah, it's not really young people who use them.
Just to follow up on the injectables, I was wondering if you had looked at the referral data. You had mentioned that the majority or over half of the pharmacies that you were working with actually gave a referral for the injectables. And I was wondering if you had done the analysis the other way around, and how many actual, did you look at the data regarding injectables being delivered at health facilities, and how that contrasted with those being referred?
The availability, or whether
young people were actually accessing the injectables, given the numbers that were going to the pharmacies and getting the referrals. Was the commensurate number, did they actually go and get the injectables?
No, I did not look at that. The ones that and I would say that is another, you know, again, with all the funding in the world and all the time, something that would have been really nice to look at, because so much of what people said they appreciated about pharmacies was spoken about in comparison to the natural opposite, which was perceived to be public health facilities. It would be really, really nice to like take a step back from the pharmacies and then go to the public health facilities and see what things look like there. But no, I didn't follow through with that one.
Mm-hmm. And then my final question is related to the policy implications. You spoke about the quality and how to beef up the quality of pharmacy delivered contraceptives. But I'm wondering, there's been a lot of talk about youth-friendly services in the public health facilities. There's a lot of data around that. And I was just wondering, if a government was going to invest, where should the investment be? Should it be to cater to youth desires to get a quick contraceptive, regardless of quality? but just to have more access? Or would it be to beef up the public health system to provide appropriate counseling in a youth-friendly way, given all the criteria of youth-friendly services?
I think, yeah, it's a good question. The issue with youth-friendly health services is that youth-friendly, like the criteria for youth-friendly health services are based off of the criteria for what quality health services look like the health system's criteria. And so I think one thing that's interesting, and I've realized this stepping out, like having existed in the silo that is SRH, and then through this exploring the health systems world a bit more, is that there's a lot of effort that's poured into trying to make services youth-friendly. But if you're in an environment where quality health services in general are just difficult and there are a lot of challenges to those, then I'm not necessarily convinced that youth-friendly health services are going to become this shining option in an environment where quality service in general and quality service provision is difficult. Additionally, I would say that something that I think about a lot is what I remember, like when I started working in this area, I was not very far off of the UN's definition of what a youth is myself. And so something that I used to see when I looked at my colleagues at WHO who were working full-time in ASRH and focusing on the public health sector is there was a time when it doesn't matter how friendly or shiny a service is, I would not be caught dead going to one because you might be seen and you'd still have to be seen crossing the street and you'd have to have a conversation. And so I think when that's the reality, it's what we need to do in settings like Kenya is not put a ton of effort into boosting up the private sector, but rather make sure that we're really investing in the public sector's regulatory capacity of the private sector. So to make sure that the Pharmacy and Poisons Board, who had 6 people to inspect 6 counties worth of private pharmacies, is more adequately resourced to make sure that where young people are going to go, they can get good qualities. And then again, I think with the task sharing that we're seeing in contraception services more general, in a setting like Kenya, where there is genuinely a health workforce problem and an infrastructure limitations, if we can task share certain services to university educated pharmacy personnel, like the provision of injectable contraception, which is what the latest WHO recommendations say is allowed, then that means that for the limited bandwidth that the public health sector has at present, we can make sure that we're using public health services judiciously so that the people who are going for contraception services in the public sector are getting IUD insertions, they're getting implant insertions, which are things that medical doctors and nurses should be doing.
Great. Thank you very much.
Thank you.
Excellent. Jörg, you want to go next or you want to stay last and let our external examiner go next?
Let's first go with the external and then I take what's left over.
Perfect. Thank you, Jörg. Over to you then, Sarah.
Hello. Can you all hear me okay? Great, thank you. Thank you very much for an excellent presentation. I was extremely impressed with how you managed to fit so much information into a very well-structured and engaging presentation. So thanks very much for that. I'd like to start, if possible, with quite a methodological question. You used grounded theory to analyze and shape your findings, and I thought that was quite maybe slightly unusual in a situation where we already know a fair amount about the theories behind or thoughts behind how and why people access services. So I just wondered if you could talk a little bit about why you use grounded theory rather than maybe some of the already existing theories or frameworks, and what you thought it really added to your thesis as a whole.
Thanks, Sarah. And I would say it was informed by grounded theory because I have some qualitative research colleagues of mine who I know if you are a purist when it comes to grounded theory, this would not necessarily qualify as it because a systematic review had been done beforehand, and then I come in with quite a lot of background myself in ASRH. So I think the elements of grounded theory that made it most appealing for me was this idea of being able to have both inductive and deductive coding at the analysis phase, but also this ability to have an iterative process of data collection, which was really critical for the qualitative methods. because, you know, I tried to go in with a very open mind saying, I know what I know about pharmacies, but there was very little data that had come out of low and middle income countries from the systematic review. So I knew that some of those initial interviews that we were having with both stakeholders and pharmacy personnel and young people were going to really structure what the rest of data collection looked like. So what I was able to do, and I guess the way I used grounded theory while data collection was going on, was to be able to have some pretty heavy debriefs in the first stages of data collection and interviews that were taking place that we then used to modify and shift and refine data collection instruments as we went on. So we were able to kind of follow lines of inquiries based on what we were seeing as the data was collected. But I will say also, I think from a grounded theory purist perspective as well, you're supposed to just look at the data and then, you know, come up, propose your own theory. And so I would say, again, at the end of this, at the point of data interpretation as well, I had my own buckets of what I thought a theory looked like, but then because I know there's been decades of work that's been done in family planning, in young people in family planning, and then in health systems, which is where my ultimate framework, that world, it ended up coming out of, nothing related to SRH. I opted to kind of take a step back based on my sort of nebulous theory and see where in the literature it fit.
Okay, thank you. My next question is slightly been preceded by Casper's, but mine was a bit more sort of broader, really. And again, it's talking about diversity of adolescence, really. And I was also going to ask a little bit about gender, not specifically about patterns of usage, but also more about whether there might be aspects of pharmacies that are more attractive to men and women, given sort of that obviously sexual relations are very gendered and approaches to them are very gendered, and that could be an issue. And my second part of that question was also about age. I realise that you've got limitations around ethics, etc., about under 18s, but I wondered if you could talk a little bit about access for the under 18s, whether you'd gained any information from, for instance, key informant interviews, because obviously in Kenya sexual activity very often starts long before the age of 18.
Yeah, very good questions. So for the gender aspect, it's really hard for me to think about the gender components and how suitable or not suitable a pharmacy is without, again, naturally thinking of the opposite of why young people and young men in particular might feel closed out of public health facility services. And I feel like that's been pretty decently studied, where we know, it's very much, it's a place, public health facility services are a place where you see, married women or mothers with young children, and that's what you see. And so to see a young teenage man or male show up for services is not, it's maybe not an environment in which they feel most welcome. With regards to how they felt in pharmacies, it was, I think they saw the interesting assumption. What people would say is that in public health facilities, you see the personnel turnover because someone might rotate out of an area and get sent to a different part of the country. They said in pharmacies, by contrast, the person who was there was a familiar face. And so you would see them more often. You might go hang out with them and, go grab a beer after you finished work, or just go hang out at the pharmacy because you're talking to a friend. And so I think that dynamic, and the fact that at least in our area, the people behind the counter tended to be on the younger side, just gave young men a bit of a feeling of talking to peers. One thing we did find, which was interesting, but we didn't get to explore much because the data wasn't thick enough for me to really say much about it, was that there's definitely seems to be a preference for people to interact with people of the same sex. So there were a couple of anecdotal interviews where young men said, yeah, if there's a young woman behind the counter, I just keep walking. I'll go to the next pharmacy and wait until I see a young man. So I think that was an interesting finding. And then with regards to what you said about age, I mean, absolutely agree with you. I think in an ideal world, it would have been nice to capture the full spectrum of youth, 15 to 24. Pragmatically for this study, in addition to the ethics considerations and need to get parental consent as well, a very real factor that set the constraint of this study was, again, the fact that it was nested in a broader one that had set 18 to 24 as the age range. But yes, I mean, I couldn't agree. I couldn't agree more, rather.
Okay, thanks very much. Sorry if you heard my dog in the background there. I just quickly muted it. Yeah, so my final question, I'd like you sort of maybe just to say, if you were doing this study again, and I'm sure that the idea fills you with horror, is there anything particular that you think you might do differently? And also, if you were going to do a follow-on study, what do you think would be your priority for an area for study?
Oh man, that's so hard. I think, well, one, if I was going to do a study, if I was going to do it differently, it would be fantastic to spend more time in Kwale than I actually was able to. I think I spent a cumulative of about 3 months and a little bit more. And so there was a lot of data collection that was compressed into a limited amount of time. And I'm very fortunate because I had fantastic research collaborators who I've been working with for several years and had been to the area before, so it was quite familiar. But you know, you just feel like there's only so much you can do. What was so interesting to me was just how private pharmacies kept getting compared to public health facility settings. And so I think understanding exactly what the dynamic is, I feel like I only saw one side of the story, and I realized that the literature is filled with plenty of information about how public health facility services are perceived. But I think since what I'm positing is that we need to have a web of contraception outlets, it's really important to understand what role facilities currently play within that. So that's something I would have liked to explore further. Another thing I would have really liked to explore, and I think needs to be explored, is this idea of private pharmacies being businesses, and whether or not that inherently makes them not good as a service provider, because that was a concern that kept cropping up, this idea of like, yeah, they provide good services, but I'm not sure you can really ever trust them because they're just business owners at the end of the day. And in my opinion, being someone who owns a business is not necessarily out of alignment with the fact that you can still be a member of the health workforce and care about health service provision and quality health service provision. But I think the research has not been done to really talk about, when you're talking about pharmacy decision-making, you know, where's that tension, and is it as much of a tension as we perceive it to be? So that would have been very interesting as well.
Okay, thank you very much.
Thanks, Sarah.
Excellent. Thank you, Sarah. Last but not least, Jörg.
Thanks a lot. Also from my end, Lianne, excellent presentation. Thank you so much. This is for me really continuous. Higher education, it's the 5th PhD defense within 7 days. Kaspar was chairing one. He's now on the other end. And Günther already chairing the second one. I had a chance. So really good, but I must also say I'm almost ready for vacation. Good. 4 points. One is, Kaspar already touched a bit upon systematic reviews. Tell us a bit more precisely what exactly is it, how is it done, and then for you, you mentioned the Prisma, what are for you the 3 most important features or items?
So a systematic review of the literature is so basically when you do a systematic review of the literature, you are saying that what you are going to do is cast a net that allows you to capture any and all items that are related to your research question, whatever it is. And so it's different from a scoping review where you might just Google some things and find some articles that give you a general idea. And it really can be a quite time and resource intensive procedure. So the way that you would do that is you would look at a variety of databases. PubMed is probably the most well-known one. And you would take your research question and you would deconstruct your research question and make it into, you would translate your research question into a variety of search terms. And so when you take keywords and special terms called mesh terms that allow you to literally construct a digital net that ensures that when you throw that net into one of these big databases that collates all the articles that are published, that what you're pulling back will capture with some confidence everything that is relevant to your topic. You then have to go through this incredibly tedious process of screening all of the screening all of the titles and abstracts to see what's relevant, excluding most of them, and then full text screening whatever's remaining, excluding things that aren't relevant, and then and only then can you extract data and hopefully come to some sort of answer to your research question. With regards to PRISMA, it's been many moons since I've looked at the PRISMA checklist myself. But things that are quite important to me personally is the idea of having dual screening. So usually at the title abstract phase, and sometimes even, sometimes for data extraction and full text review, you want to have not just one person making decisions as to whether something is in or out, but rather at minimum two. And I have found in my experience doing systematic reviews, that's really critical because humans are fallible, we make mistakes. You know, when you're on your 1500th title of the day, you glaze over. And so that can be really important. I think that assessing the potential for bias in studies, which comes at the phase of data extraction, assessing bias and making a judgment as to whether you can trust the results of that study and seeing how credible they are is a really important aspect as well. And then for me, how you craft the search strategy and making sure that that's available so that your study is replicable is a very important aspect.
Excellent, thank you so much. Maybe just a quick follow-up still on systematic reviews. You then also mentioned in your response to CASPAR, you found a myriad of items or interesting topics for you. Of course, has to do also with you have a broad research, quite qualitative. What would be other topics where you think a systematic review is really extremely worthwhile, and you then also move into quite easily the meta-analysis and you get a clear value with a confidence interval? Just what other fields of inquiry you think a systematic review indeed is very well suited?
I think anything, I think clinical questions about, the appropriateness of one treatment over another.
Excellent. That's already, this is exactly what I wanted to hear. Very good.
Okay.
In the first, I come now to my second question, and it was quite interesting. One of the items you mentioned, which you think is important in the systematic review, was also the issue of assessing for bias. Let's stick a little bit to bias now. And I would like you to reflect in some of your studies, and now specifically not the systematic review, but in some of the other studies, the more qualitative one, where is there potential bias? Explain it a bit and exemplify.
Are you talking about, sorry, you're just with that I conducted or
of course.
Broadly? Okay, so in the study that I conducted, on the quantitative side, for sure, you always have the potential for, well, you would have had the potential for sampling bias, but I think we really mitigated that by the fact that we had random selection of young people. Then you could also have response bias. We are talking about sex, and I think that applies to the qualitative side as well. You're talking about sex, and sex is something where there's a lot of very strong social and community norms, and the person who is implementing whatever it is, the interview or the survey, is a member of that community. So if you're being asked about sex, you might check yourself and answer based on how it's socially desirable. The way that we kind of mitigated that is for the quantitative survey, when we asked the questions from which the data for this pharmacy study were pulled, young people were actually handed the tablet and invited to enter in the answers themselves. Because the rest of the survey was very much about knowledge and attitudes, etc. But we were asking here about people's sexual activity. So to mitigate any sort of response bias or social desirability bias, they were handed the survey themselves. They filled it out and gave it back to us.
Good, very good. Maybe, and you clearly emphasized you're a big fan of the mystery shoppers. I would like to hear from you, nevertheless, where your mystery shoppers actually also brought in considerable bias. And I would then like to know from you, how have you addressed?
So there was in the exercise themselves, there was the potential for observational bias. So because of our ethical considerations, we had to let pharmacies know we were coming. So there's obviously the chance that everyone was on their best behavior and acting the way that they thought they should be acting. So that's one area. And then, of course, you know, our mystery shoppers themselves are humans and fallible, and they're having a very subjective experience and being asked to comment on what is a subjective experience. So the way that we try to standardize what the mystery shopping exercise would be is that we took our 4 mystery shoppers into a half-day workshop, and based on some of the initial findings from the qualitative research, we developed personas for them. So we developed a uniform character that each of them would be able to go into all 48 pharmacies with. And so they would be going in with the same story, the same character, and hopefully at least to the pharmacy personnel, presenting a similar persona that the pharmacy personnel could react to. We also, for the checklist itself, they filled out a semi-structured checklist. We did our best to keep the things that they were asked to comment on fairly objective. Like, did they get what they needed? You know, what was the sex of the person behind the counter, etc. We did ask some qualitative related questions, like how satisfied were you, etc. But even when we were looking at that data afterwards, it was really hard to reliably interpret that, so I didn't include it in the end.
Great answer. Yet, would you have seen a difference? You mentioned 3 mystery shoppers. The first, or 4, the first time they went, and then the second and the third. What I want to know from you is the selection of these mystery shoppers, and then also the way you trained them. Basically, they are not shy any longer. And in the initial introduction of your thesis, you said, oh, for many people, this is some of the most embarrassing thing to go and ask for a contraception. So I wonder whether actually the selection of these mystery shoppers was already so much biased that basically you don't get a useful answer.
I mean, I disagree slightly in that we recruited mystery shoppers, and we actually gave them a persona where we wanted them to be shy. So the mystery shoppers weren't sent into 48 pharmacies and like with a good luck and have at it. We actually piloted their persona in 2 pharmacies before they got started on the exercise, and we were trying to emulate what a typical purchaser looked like. So it absolutely would have been very out of character if a young person had walked in and said, give me your finest emergency contraception. Thank you so much, I'm going. So the personas that they were emulating, if they were able to fit, like if they were feeling nervous, that was something that we wanted them to. If they weren't feeling nervous, we needed them to pretend to feel nervous, because they were we wanted them to look like a typical young person in that setting.
Good, excellent. My third one, now more on the outlook. You mentioned that these pharmacies actually are an interesting place because of the how they appear, the staff, and so forth. Yet I'm wondering, could you think about some modern schemes of basically developing a tool or whatever which really fits the adolescent, and basically they would not even need the pharmacy any longer? Or I'm not yet very concrete because I want you to think. Can you think about the scheme where somehow the adolescent would even feel much more comfortable to get their contraceptions?
Yeah, I think there's a lot of, we're seeing a lot of that right now in the digital health world. So the trial in which this pharmacy study was nested in was a digital health trial. And when looking, the digital health trial was just providing SRH information to young people. And so what I've seen from other people who work in the digital health space, for example, is almost marrying digital and pharmacy access. So making it so that a young person has access to a service that gives them SRH information. They've looked at something about contraception and they're like, oh, that looks really interesting. I think I want this. There are mechanisms by which they can either order or be referred to pharmacy or facility services that have been vetted as being, you know, okay for you. Like these are good, the people here will treat you well, like we can vouch for them. And so I think we're seeing really interesting referral opportunities. But then also, I think, you know, as digital technology penetration goes through Kenya, which is, you know, so advanced and so saturated already with this. I think that there's a lot of potential to incorporate digital and you know, for example, put in an order like you see in the UK right now. You can online or on your phone put in an order for an eye test, self-test that you can go pick up at a pharmacy.
Mm-hmm. Excellent. This is exactly what I also think with this digital revolution, apps, and you actually don't even encounter an individual, but you just order and so forth. Final point, what are SDGs?
The Sustainable Development Goals.
What did your study contribute to? Which one?
3, of course. 3.
Only, or is there anything else?
There's 3, there's 5 for gender equality, you know.
Okay, good. So you know what this is all about. Very good. What is the contribution of your study to universal health coverage?
I think the study, I mean, I can show you a slide on that. You're going to have a slide, but basically...
Good, we do that then for later on, yeah. Good, so that also seems fine. Final point, you did all this study and all of a sudden comes COVID-19, you cannot even access the pharmacies any longer. What are the implications?
Oh, see, I disagree. I think we've seen self-care really take off during COVID. So because facility services shut down, or a lot of facilities have had to switch their focus to providing COVID-related care, or people don't want to go to a health facility because you're going to run into someone who has COVID, we've seen a lot of uptick in the concept of self-care, which involves either accessing information and commodities digitally or through pharmacies. So I think even in Switzerland, but definitely around the world, we're seeing a lot of people who might want to go to a doctor, maybe just poking their head into a pharmacy and seeing if they can get in and out and avoid any germs.
Perfect. I'm highly satisfied. Handing back to the chair.
Thank you, Jörg. I guess we now have time for a few questions from the audience. Please raise your hand or just speak up. I think it's quiet enough.
I'd like to ask a question. This is Peter Winch in Baltimore, and I know you're focusing on contraception, but did you look at menstrual hygiene management products, or do you have any observation about their availability and where young girls get them, or do they purchase them?
No, Peter, and I think that would have been actually really, really interesting. And I would attribute that just to the fact that when I started this study in 2016 and started this line of inquiry, then menstrual hygiene management was not yet having its day in the sun. I think in the last year or two, we've seen a lot of attention to it, and very warranted attention. But I actually think that, I think that would be a really, really interesting question to find out. But I wouldn't want to comment.
Great. Other questions?
Cassian?
Hi, my name is Cassian. I'm from Rwanda. So in Rwanda, we have the same process. Young people going to different private pharmacy. But the challenge now is the emergency contraceptive pills are more expensive in a private pharmacy compared to the other platform. So what kind of regulation can we put in place to make sure that young people may have more access compared to the other group?
Yeah, it's a really good question, Cassian, and I think one that not just Rwanda alone is struggling with. It's I would say a big limitation of pharmacy access as services are currently structured in many countries, which is that pharmacy purchases will tend to be out-of-pocket purchases. And so the burden falls on the young person in this case. I mean, I assume, and I know Rwanda has done really interesting work in this, that as insurance schemes start to grow and more people get insurance, I think you can't really leave pharmacy services out of this broader scheme that's growing. But it's a challenge. So one option you could look at, for example, might be to have pharmacies have access to some of the same essential commodities that are procured through government structures, but have them not be able to charge for those. just because you can't procure something from a government at a very low price and then sell it at a profit. So if you could find a way, and this would have to be there'd probably have to be some sort of incentive structure offered, but make sure that pharmacies are also a source of subsidized commodities. I think that would work, but it is a challenge, and I would say a limitation for things as they stand currently.
Great, thank you. Any further questions? All right, I guess we will conclude here then. The committee, is Anna, you clapping, or you want to ask a question? I think it's just clapping.
I'm just clapping.
Thank you. So I guess the committee will now go to a private room. Barbara, can you help us with that?
Sure, I just wait for your go. So now I will create the room, and I learned from Kaspar that you will join in the institute, like face to face, but we will anyway just create the room for the others to join.
So where do we meet, Kaspar? You're muted. You're muted, Kaspar.
I noticed, yeah, I know, but sometimes, you know, I think quicker than I act, so sorry for that. I would propose that we go quickly to Jörg's room.
Perfect.
Yeah, I'm come over.
Perfect.
Okay, then I
Will you
sign
send
now
another link to us?
No, you can just wait. You will now receive a sign, and please enter the room. You just click and then you will be there. No worries.
Okay.
Just a second, I have to create it first. Okay, so you should now receive the invitation. Just click on it. So Lianne, I think it's fine. They are there. Congratulations.
Thank you.
Well done. Amazing.
Me. I'm happy I brought that intellectual input.
So good.
So well.
Thank you.
You nailed all those questions.
Every single one.
Yes, you did. It was so good.
I'm sweating profusely, but no one needs to know that.
Well, now we all do, so it's great.
It was so good.
Thank you.
I've never, or very rarely, do I see Jörg being like, that's exactly what I wanted to hear for every single question.
Now we know that all he wants is just that we know the SDGs. Oh yeah,
definition of a systematic review.
Oh, good.
Yeah, I wrote down all the questions.
I know. I was thinking. I was like, God, I did that systematic review about 4 years ago.
Yeah, and even asking about the PRISMA guidelines, the specific steps that were best. Oh well. Did well.
No. Oh my goodness.
Now you're a free woman.
Cal, are you in the next room?
Yeah, I'm in the kitchen, but I listened to it. Well done, honey.
Thank you.
You were very charming throughout, and they were very impressed, I think.
Thank you.
Congrats, Lianne. So confident. Good enough.
Hi, Peggy. No, I'm guessing because it's, 7 in the morning on your side, no video.
You woke me up, that's for sure.
Yeah.
Yeah, Lianne, you didn't consider us Californians over here very well.
Rachel, hello.
Hey, Peggy.
It's like a reunion of people it's like an episode of This Is Your Life. Thanks for coming, guys. It means a lot.
The at
You
these
did a
baggy
great
eyes.
job, Lianne. I enjoyed it. Hey, Peggy.
Hey, Mom.
Showing off my baggy eyes.
Oh man, I'm very, very excited for this to all be over at this point.
How are you going to celebrate it?
Well, people who are in Geneva are going to go jump in the river after this, and
Oh,
then
fun.
barbecue, which will be nice.
Is it not super raining where you are?
No, it's really sunny here.
No,
Man.
literally the opposite. You can't even see out the window. It's thunderstorming.
Lucerne, man. It's not ideal. How's Basel?
It's sunny.
Perfect. Great. Yeah.
Maybe I'll jump in the Rhine here.
Oh, yeah, it's the Rhine over there, isn't it? We've got the Rhone.
Yeah, I know, but
Mm.
state of itself.
Congratulations, Lianne. I'm not going to jump
Thanks.
to you because
Don't jump in the Thames.
I won't.
Ooh, I see Professor Peter on there. Although he's muted.
No, Lianne, I'm here.
Oh, hello.
Hey, Peter.
How are you?
Good.
Good. So Lianne, are you really jumping in the river?
Yes, Peter. At the end of a dissertation defense after 4 long years, I think jumping in the river is
Are you jumping off one of those bridges?
yes, actually, because you can do that. But the one that you jump into because it's fun, not because you're trying to end things.
Okay.
Yeah, it'll be good. I was terrified to answer the qualitative research related questions with you on the line, so
Oh,
just as
you did fine. You did fine. No problems. You think they're talking about you or telling jokes?
I really, I really hope they just like figure out what they want to do and then like let's just let her stew for a while. I think they had tech issues on the digital defense I watched on Monday, and so they were gone for a long time. And I think the person who was defending was getting a bit nervous, but it turned out they just had connection issues.
I think they're talking about their kids and the
I
sex
know.
conversations they need to have.
Right?
They were asking for advice, Lianne.
They're gonna go home and be like, real talk, kids. Hey, Kat. Hey, Jill.
How long do they normally take? Is there a
10
normal?
minutes?
Okay.
10
Oh, that's
10
quick.
Yeah. Because they go.
Variable if it's more dramatic.
Because they go in and they do, what is it, AC and Alia? It's like two-thirds of the grade is based on the written dissertation, 1/3 is based on the presentation. So I see like, doing the math literally right now.
I'm sure you did well.
Oh my god.
I picture them rolling dice.
Yeah, I know. Exactly.
Do you think that's the first time they've got advice on how to talk to the kids about sex during a defense?
I wanted to be like, send them in here. Sit down. About feelings.
Maybe that'll be part of your grade. You'll have to talk to them individually.
Nothing would bring me more joy. If anyone has teenage children they need me to talk to, just send them to Auntie Lianne.
I will do that. I will.
100% do
We're
that.
all going to do that, actually.
Just send them on there. I mean, Kat, you're on WRS. Like, you can have like sex talk with cousin Lianne
Can we start that?
on the radio.
Yeah, can we do that?
Answer all your questions.
With Dr. Lianne.
Boom! We're good. But not a medical doctor. Don't ask. Don't ask really specific clinical questions because I will tell you should probably see a professional and get it checked out. Yeah.
You gonna watch your recording tonight?
Oh God, no.
Popcorn?
No. No. Oh God. I hate watching myself speak.
Yeah.
Are you going to put this on YouTube? It should go on YouTube. You should probably cut this bit out.
Yeah.
This is part of your
Still
Instagram
recording.
story.
Right.
Very long story.
Oh God. Yeah. No, it's like, it's the same reason I don't like ever being on the radio with you, Kat, is just because I think I sound like a little boy with a head cold.
Sorry, I'm trying to unmute myself to say that's not what you sound like. It took me a really long time.
I was like, there's a long silence, and everyone's like, yeah, that's not wrong.
Meanwhile, the St. Lee extended family has come up with a new game called the Mistreated Mystery Shopper.
Oh, that would be amazing. You can put that on stage.
We've had a small commentary throughout the entire last hour. I look forward to your
processing all of it.
Yeah, you'll be able to read it and get a full account of how we felt every second
all seconds
of the way.
Good Lord, 70 notifications. Good. Nick Mandalia, I see you there, being a creeper. How's London?
Now you find out if people really listen to your dissertation or not.
I know, or if they've all like walked away and they're just like, yeah, logged in.
Maybe they can't handle the nerves.
I know.
I am very nervous right now. Anyone else?
At this point, as long as I pass, I'm just...
They all said impressive, perfect, excellent. That wouldn't have been cool if they had said that.
That's fair, because they're not American, so...
Brilliant. Exactly what I was looking for. That's the perfect answer.
And there was the one where you said 2 words that I didn't understand, and he was like,
Oh,
okay,
yeah.
great.
What even was that? I was so quick. I have no idea what you said. And it was what he wanted.
I think it was the clinical answer.
Oh, right.
Like the meta-analysis is really useful, yeah.
When you have an easy clinical outcome, yeah.
You were very efficient. You gave the 2 words you needed.
I know. I was like, oh God. I know. I saw another defense where like he's looking for something, and then it's terrifying because if you just happen to approach a question from a different perspective and it's not what he's looking for, he'll keep like. So I'm glad I happened to land on the right one, or the one he was looking for.
Favorite answer was when you said, "Give me your finest contraception." I mean, that could be the title of your just.
Give me your shiniest contraception.
Yeah. The reality is the worst mystery shopper is you, because you're way too confident in that.
I'd walk in there and be like, hello, I am a nervous youth. Give me all of your contraception.
Look how nervous I am.
Or you just put on your scrap face when you try to look nervous and it's too hammy.
And I'm not a good actor. Although I will say I had to go to the pharmacy earlier to pick up allergy medicine. And I was telling Cal, the way pharmacies are set up in Switzerland, I would be super uncomfortable getting contraception from there because it's all these windows right next to each other. And like someone will be at the counter right next to you. And then of course everyone's listening in to what everyone else is trying to get. So I looked at this stuff and I was like, honestly, some of the Kenyan pharmacies would have been more comfortable getting them from than like these 4 countered Swiss pharmacies.
So how are they in Kenya? How are they literally set up?
If you picture, like, they're kind of like little, a lot of them are small rooms that you can go into. So some of them are big and they have 3 or 4 people behind a big counter. But a lot of them are quite small. So you would go in there and there'd be all these drugs against the back wall. And then you would just like get what you want. You're the only person there. They're just like kind of hanging out the way you would at a shop, and then you go. Versus like a pharmacy here, they're just so open. And even if it's just you and that pharmacist, their colleague is right next to them. And that's just, I don't know. I don't want to be asking for emergency contraception and have them be like, so the condom broke.
That was really nice that you drew on that. I thought it made a lot of sense for them, I guess, being based in Basel and thinking about their own health system here in Switzerland.
Yeah.
And then when you talked about self-care, and COVID, I thought that made it really connected to the current situation really well.
And I like the criticism of the Swiss pharmacy system.
I know. The fact you have to ingest it on site, that's a little bit messed up.
And you were saying men can't buy it either?
Men can't buy emergency contraception.
Pablo called it medieval.
Exactly. It is medieval.
Do you think that's because they are resold sometimes, or is it just because they want to control how it's taken?
Yeah, it's not uncommon for reproductive health commodities. Like if you think about like cold medicine, certain types of cold medicine are probably more easily to be abused than emergency contraception. So there's archaic notions that if you take emergency contraception frequently, it's really bad for you, which is not the case. And so I think it's both that and the fact that you take emergency contraception after you've had unprotected sex. So there's this notion of like you were irresponsible and now this situation. So like I think there's a bit of like societal policing and moral policing that is sort of inadvertently or subtly built into these processes where you're like, oh, you're going to come in here, but like you need to think about your choices and what you did.
Yeah. And you were saying that you thought maybe men can't buy it as well because there might be a perception that they're coercing their partner.
Which is just like, yeah, I find it a little bit ridiculous that men cannot buy emergency contraception here anyway. Or you have to go in with the person who's going to take it.
I was really taken by the concept of the young and very cool data collector.
I know. It was like hanging out outside. Yeah.
Did you do casting for that?
I mean,
not cool enough. Get out of here.
Move along. This will not work. We did like, we found someone, we were like, we need someone who's not going to intimidate people and who's like going to just be chill about it, being like, hey, so I bought a condom. By the way, there's a study. You want to do it here, as opposed to being like, you know, someone who's like, hi, I'd like to talk to you about your contraception purchase, and just like, already feeling awkward, feeling even weirder. But yeah, he was very chill. Anytime they feel like coming back, they should feel free.
It's taking quite some time, huh?
I know.
Lianne, it was really good. Great job.
Hey, Sarah.
Congratulations.
Thank you. When are you planning your defense for? End of this year or end of this next academic year?
Yeah, I hope so.
Good. With your twins in tow. Impressive woman.
I mean, it's better to be done, right?
Yeah, so true. I can hear Hendrix in the background.
Yeah. He listened. He thought you did a great job.
Genius. Excellent.
Can you imagine that? I heard you talking with the external reviewer at the beginning. She's like, it's so cruel to make it public. But then I'm like, what if Lianne was sitting all alone in a Zoom room just waiting for them to come?
It's so sad. I know. Yeah. That just feels very intimidating to have to, like, I don't know, be in a room with your reviewers.
I was actually surprised that we were allowed to stay on for this portion, but it was, I mean, you know, they were asking you tough questions, but I didn't feel like
they were kind. They were not,
get you to misstep. Yeah, so it was actually really nice as a participant to be able to watch that.
Yeah, they were not like doing what I think they do in the States, which is like, if you cried, mission accomplished. Yeah, I imagine that's kind of why they let you do that. That, and I don't know, I think Alia and AC, we were talking about this, but this idea that because for us, you can't really defend until your stuff is already accepted, there's not as much that they can really grill you on, right? Because it's not like they can say, well, you know, I'm not really sure this is publishable, so you need to defend that. It's more like, well, this is out in the literature, so if I have a big problem with it, it probably shouldn't have ever made it out in the literature. I don't know if that's true.
That's not always the case. Sometimes you can defend, from what I understand, you can still defend papers that have been submitted but haven't been accepted. So those can still form a part of your PhD, but I could be wrong.
I think it depends a lot on your supervisor. So I also have Casper, and I think he would like to see them accepted before.
Mm-hmm.
But there are some who defends who doesn't have any accepted, not even submitted, I think.
You know somebody that has?
Yeah, there's been a few.
Yeah, AC and I were not given the impression that that was allowed.
Yeah, Did you write a lot about COVID in your discussion?
No, because COVID, no.
Are you expected to write about COVID?
I feel like everyone who works in health right now is expected to like start an email with like, in the time of COVID, how's your weekend? Can we have a meeting?
Imagine in your discussion, you have to rewrite it.
No, I'm so over having to do anything with COVID anymore. I have to reference it. Too much. Mom and Dad, are you guys staying inside right now? North Carolina is in the middle of its second wave and things are not looking good. Or it's first wave. They're still first waving.
What's that?
Are y'all staying inside?
We haven't changed a whole lot the way we do things. I mean, I still go shopping and stuff.
You guys.
But it's not like we go outside a whole lot in the first place.
Your daughter's in public health and you're embarrassing her by saying in front of everyone that you go grocery shopping.
Well, we got to get food. Someone's got to provide food.
You do wear a mask.
No, but that's to protect others, though.
Lianne, are you not grocery shopping? Are you doing all delivery or what?
No, but we're also, I think Switzerland's only just about to hit a second wave. Is that right, Aaliyah? You said we had like 150 cases yesterday countrywide.
I think it was like 137 that were reported, but yeah.
In the entire country. Yeah.
137 cases yesterday?
Mm-hmm. Was that yesterday or day before? Days blend together.
But it's been doubling for the past few days.
Yeah. And they haven't changed, the federal government was talking about making masks required, but they haven't yet done that.
They have now on public transport.
Yeah, from Monday, I think we were required to wear masks in public transport.
I mean, after this pandemic, the hell if I'm ever taking public transport again, I'll be on my bike constantly. Oh, they're
buying a car.
It's the most AC thing I've heard all day. Just get a Jeep.
On my bicycle, guys.
Everyone's coming back.
Yeah, boy.
It breaks my heart because we had just started to eradicate single-use plastic bags, and now it's like we went back 15 years.
Yeah, everything disposable.
So in like 10 seconds, you're about to become a doctor. How do you feel? Pre-doc, like right now?
So tired, to be honest, but very good. Yeah, good, I guess. It's weird to think something you've worked on for like 4 years is coming to an end, so that's a bit surreal. I know.
Dream. Jump.
What's next, Lianne?
Yeah, I'm happy for you, but
I know. I'm so sorry, ladies. There's Jörg and Gunther. Where's Casper? I don't see him.
He had to walk to his office.
Long chair.
Caspar is on his way back to the office, so we'll give him a few more seconds.
And it looks like Jörg's having some issues connecting to audio. He's slowly connecting.
Yeah, I think he's moving because he moved the computer to the main desk, so I'll... All right, Jörg is back. Is Caspar back? Yes, he is. Perfect. All right. Well, let's start with the good news. Congratulations, Lianne. You have passed the exam. You have now completed doctoral training and have been awarded the grade magna cum laude. The Faculty of Science of the University of Basel confers upon you the title of Doctor of Philosophy with the proviso that you must first fulfill any remaining obligations. And now comes the fun part, or maybe we can do first a little applause, virtual at least.
Thank you.
Congrats.
Well done.
Well done.
Bravo.
Thank you.
Okay. And now the official part. I now ask you to make a solemn promise and vow, namely that you will always conduct your scientific research honestly and with a full awareness of responsibilities, that you will consider scientific activity to be a serious obligation, and that, should your future activities put you in a position to serve the cause of science, you will act always with conscientious thoroughness and impartial objectivity. You now have to say this I solemnly promise and vow.
This I solemnly promise and vow.
Excellent. Congratulations, Dr. Gonsalves.
Thank you.
Ja, was hätte er gesagt?
Usually this would be a time for a picture now and the handshakes, but I guess we just say congratulations.
No, maybe Adriane, would you like to say 2-3 words on our behalf? I think you have been the, let's say, the person who have been the, let's say, the person behind, in a certain way, this thesis, at least the person which has followed up over the longest time. Maybe you say, address some short words also to Lianne and on our all behalf.
Sure. Well, it's been a complete pleasure and a journey, Sarah. You've done a great job. I mean, since the very beginning, it's been really a pleasure to work together. And I think that you have worked with tremendous diligence, despite all of the multiple challenges of working within the confines of WHO and all of the different structures, the multi-layered structures that you were working within. I see Peter is on the line as well. I think we can all agree that that the work was exceptional and that your efforts have been quite, particularly in the last year, in pushing this to conclusion has been extremely impressive. And it's been really an honor and a pleasure for all of us to work with you. And we wish you all the best for the future and for your next steps in life. We know that it'll go well. Congratulations.
Thank you, Adriane. And thank you. I could not have done this without you and Casper and the many, many drafts of everything I've ever written that you went through and helped me with. So I'm grateful to both of you, and then also to just University of Basel as well and the Swiss TPH family. And then I want to, because I know Professor Gachangi is on the call, thank him so much. None of this research would have been possible without the International Center for Reproductive Health. And so, you know, my warm love and wishes to the whole ICRHK team, and heartfelt thank you to you and Jeff and everyone else.
Lianne, maybe, I don't know if you are then aware about, even if you are now allowed to call yourself doctor, it's in fact those doctor designatus, Dr. Des, I think there are still small formalities to be done. Maybe we can interact once in the next days on those formalities, so that you have then really also the full diploma. I think the Dean's office will send you a tentative diploma, but you will get then the full diploma once all these formalities are cleared.
Great.
But we can do that separate. We don't need to do it here. And again, also I can just only align also to Adriane. I think she very nicely summarized all your achievements, and I'm sure you have really done also a most valuable thesis, not only for yourself, but also for many, many more. And in that sense, many congratulations from my side.
Thank you, Casper.
This is when we would raise the glasses, but
yeah.
Virtually.
I have a Pepita bottle in my office here.
Great. Well, if anyone's in the Geneva area, you're welcome to come to the barbecue and a picnic. And then I know Sarah can join, but thank you, Sarah, also for being an excellent external expert.
You're very,
with social distancing.
Thank you very much for inviting me.
You're most welcome.
Good, if there are not big other laudatio, Günther, maybe we come to an end. I think this is a little bit, I think these virtual defenses have some advantages. They allow people to join which otherwise wouldn't join. But at the end, it's somehow missing this kind of yes, relief. I'm sure you have, Lianne, and then also the toast and the nice and good words, which usually would come in over a glass of wine or so. That I miss sometime, I must admit. Also to see many faces only on a photo and not in reality, but maybe other times again to come.
Thanks, Casper. Thank you everyone who tuned in from all over the world. I appreciate everyone for taking the time.
Bravo. Congratulations.
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 Enjoy the evening.
Will do. Thank you, everyone.
Congrats, Lianne. Deserve it.
Thanks, everyone.